Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday and I think you know what's happening on Sunday. But before we start, I received a very good feedback about this newsletter. And one of our dentists told me like you are giving me question with answer back to back, which is not very beneficial. And honestly, I cannot argue with what he said. What he said is extremely correct. And then I asked him, what do you think? He said, like, why don't you give us a quiz with those 5 questions and let us try to solve it during the week? And by Sunday, you give the answers and you give next 5 questions for next week, which I think is good idea. And I'm going to do this starting from this week. So this Sunday, you will see this question being solved, the 5 question I gave it to you last week. And I will give you the new 5 question to be weekly newsletter number 11. And going forward, we'll do the same. And for the previous newsletter, I would do the same. So giving you the 5 question and you solve it, and then you go to watch the weekly newsletter. So it will be more benefit for you. With that being said, let's just start it. First question from Operative. A 25 years old patient present to the clinic complaining of pain whenever she eats anything sweet. So let's stop here. And I would recommend you doing the same with long question. Do not read the whole question and then being lost. No, you read the question, decipher the information. Each sentence you read, try to get the keywords to understand what is aiming to give you as information from this part, and then go. Do not read the question like it's like, because I received this feedback a lot, like some people saying there is a lot of long question in the real exam and we are lost while we are reading the question. We are lost, and I cannot blame them. But if you try to go this way, I think it will be easier. So when you see a long question, just try to divide it and decipher the information. 25 years old, because meaning this patient has permanent teeth with closed apex, so all the teeth are mature permanent teeth. Complaining of pain whenever she eats anything sweets. The question didn't say lingering pain, didn't say pain awake me at night, didn't say patient didn't sleep, didn't say patient taking painkiller which is not working. So this hints you or give you the direction to think about reversible pulpitis. Let's read more. Radiographic examination reveals that the tooth 37 has mesial caries extending 2/3 the way into dentin. Stop. So from here we can see the radiographic confirm that the caries is only in dentin, so there is no exposed pulp. And the clinical signs and symptoms from our patient explaining about reversible pulpitis. So now you can think about its mature permanent tooth with reversible pulpitis and no caries exposure. So what you are going to do, what is the most appropriate management of tooth 37? And here giving you occlusal adjustment, make no sense. If occlusal adjustment, if you give patient new filling, new crown, and I come to you back within short like time frame, 3 days, 5 days, speaking about pain while he's biting. Direct pulp capping, there is no pulp exposure to do direct pulp capping. Indirect pulp capping, it might be pulpotomy, it might be pulpectomy, it is not, because like here the question is speaking about reversible pulpitis. But before we go to conclude between these two, let's read the article speaking about the diagnosis first. And we did a whole series about articles. I think you can find it in the left side of the screen. You go to article and then you can watch whatever you want to watch. There is like one full article speaking about the diagnosis of the endodontic diagnosis, peridental diagnosis, preapical diagnosis, and how you can conclude it. But here we speak about like a quick recap. Normal pulp is normal. There is nothing symptom-free, normally responsive to pulp testing. Reversible pulpitis, subjective and objective finding indicated that the inflammation should resolve and the pulp turn to normal. When we say it's irreversible pulpitis, you should have more lingering thermal pain, spontaneous pain, referred pain. Asymptomatic irreversible pulpitis, when we have inflamed pulp, is incapable of healing. Additional description like no clinical symptoms, but the inflammation produced by caries exposure or trauma. This happens like when you have pulp polyp, you can consider it to be here. When you see preapical radiolucency and the patient telling you there is no pain here, so there is like silver lining between this one and this one, between asymptomatic irreversible pulpitis and pulp necrosis. Because pulp necrosis, how you say it's pulp necrosis, when the question giving you option information non-responsive to pulp testing, so you would say pulp necrosis. As the question didn't mention anything about this, so you may lean more toward irreversible pulpitis. Last two, previously treated, mean RCT has been done. Previously initiated therapy, mean this tooth has gone through pulpotomy or pulpectomy without final treatment for the root itself. So this is the recap for diagnosis. So how are we gonna think about it? The primary goal of pulp therapy is to maintain integrity and health of the teeth. Pulp preservation is a primary goal for treatment of young permanent dentition. So, and here same for the permanent dentition, like even young or adult, but this article is speaking about the young permanent teeth. And here we are going to get our diagnosis and choose a treatment plan according to this condition. We have normal pulp, symptoms free or normally responsive to vitality testing, or reversible pulpitis, pulp is capable of healing, symptomatic or asymptomatic reversible pulpitis, vital inflamed pulp is incapable of healing, or the last diagnosed necrotic pulp. According to these categories, we are going to say, okay, we are going to do this treatment, we are going to do this treatment. And as you can know from this simple information, if the pulp is normal or reverse pulpitis, pulp is capable of healing. So you might do pulpotomy, you might do indirect pulp capping. But if your pulp is irreversible pulpitis, asymptomatic or symptomatic or necrotic pulp, pulp is incapable of healing. So you are going to go for non-vital pulp therapy, which is pulpectomy and root canal treatment if it mature permanent teeth. So this was a quick recap about it. I would recommend you, if you didn't watch the article or you feel still confused, you watch it so you can get whole information about it. For this question, we have two valid options, but he speak about the most appropriate one. Indirect pulp capping, IPT, can be chosen instead of direct pulp capping, DPC, or pulpotomy when the pulp is normal or has a diagnosis of reversible pulpitis and there is no pulp exposure. The same wording in the question. Indirect pulp capping is indicated in primary tooth with deep caries that accept no pulpitis or with reversible pulpitis when the deepest caries dentin is not removed to avoid a pulp exposure. The pulp is judged by clinical and geographic criteria to be vital and able to heal from the caries insult. Objective, the restorative material should seal completely the involved dentin from the oral environment, because like when you see it, there is no plaque coming here, so no bacteria. So if you have no bacteria, there is less chance for this caries to happen again unless you have some leakage from your restoration. So this might have recurrent caries and your treatment will be doomed to fail. So here we can come to conclude this permanent tooth with closed apex, reverse pulpitis, no caries exposure. So we'll lean more indirect pulp capping, like instead of pulpotomy, because like as we said, the preservation of the pulp vitality is our goal for treatment in operative, in pedo, in everything. Hope this will be beneficial for you. If you feel still confused, just watch the article, it will be easier. Second question from prosthesis. And I realized like we don't have a lot of questions from this discipline. So in this article, in this newsletter, I will give you a lot of those questions. A patient present for the construction of Kennedy class 1 removable partial denture. Which of the following statement is false? So I think I know for sure you know about Kennedy class 1 removable partial denture, but like let's just recap it and speak about it and then speak about the occlusal rest seat, and then we can come to conclude the correct answer. The rest seat on the terminal abutment should be placed on the distal of the tooth. Retention is obtained using direct and indirect retainer. Maximum tissue coverage is desirable. Support for denture is obtained from both the teeth and the tissue. So before we dig deep in this, let's just recap the Kennedy and how we think about it. So Kennedy classified to class 1 to class 4. Class 1 to be bilateral edentulous. Class 2 unilateral edentulous area. Class 3 unilateral edentulous area with natural teeth remaining both anterior and posterior to it. Class 4, a single but unilateral crossing the midline dentulous area located anterior to the remaining natural tooth. And then we have subdivision of these classes, but the rule we are going to count it from posterior, and class 4 will be exclusively to missing anterior teeth crossing the midline. If we have missing anterior teeth does not cross the midline, it will be class 3. And we have missing anterior teeth that not missing posterior teeth does not cross the midline, it will be class 2. And we have posterior teeth missing on both sides, it will be class 1. And here we have visual to speak about it. There's a class 1, there's a class 2, and then we have modification here because we go from posterior, so the class 1, and then modification 1 and 2. So class 1, modification 2. Here we have class 2, modification 1, because like, and then you can go to read it, but like I would like you to know this because this is important. You might see simple question and speak about this classification, so it's extremely important for you to know it. As for question and as for the treatment option, you cannot get to conclude the treatment option if you don't know what's the meaning of class 1 and class 2. Okay, so we come to conclude this part. Let's now speak about the occlusal receipt and how we are going to make the preparation for it, because this is important and they ask a lot of questions about it. The outline form of occlusal receipt should be rounded triangular. As you can see here, it's triangle and rounded, and the apex should be toward the center of the tooth. The marginal ridge is where we have the base for our occlusal receipt. It should be long and wide, and the width of it to be 2.5 in both premolar and molar, because I see some dentists think it should be less in diameter in premolar, which is not correct, because like if it's less diameter, does not provide an adequate bulk of metal for rest, especially if the rest is countered to restore the occlusal morphology of the abutment tooth. So 2.5 here, round, triangular in shape, apex toward the center of the tooth. Marginal ridge of the abutment tooth at the side of the receipt must be lowered, as you can see here, must be reduction here to give the thickness, and approximately 1.5 is usually necessary. So in the vertical dimension, it will be 1.5, and horizontal, like buccolingual, it should be 2.5. The floor of occlusal receipt should be apical to the marginal ridge and the occlusal surface, and should be concave or spoon shape. So in this part, it should be concave or spoon shape and going this way. Caution should be exercised in preparing the receipt to avoid creating sharp edge or line angle in the preparation. When you have sharp line angle, so you have sharp metal, so it will have more probability to be broken. Last thing, the angle formed by the occlusal wrist and the vertical minor connector form should be less than 90 degrees. So this angle between the occlusal receipt here and the minor connector angle, this angle should be less than 90, because if it's 90 or more, it will be more prone to be broken, because this angle will transmit more forces in the junction between occlusal receipt and minor connector, so it will be broken. So this angle should be less than 90 degree, or we can say in another way, acute angle. Otherwise, it will be broken. Occlusal receipt is important for you to know the criteria, how we do it, stuff like this. Okay? So let's go back to combine it both together. So we have plus one, which is this one, bilateral missing teeth. And the question asking about the occlusal wrist on the terminal tooth, which is here. Occlusal wrist will be distal or mesial. As you can see here, the occlusal wrist should be mesial, not distal. Why? Because distal, we are going to use the distal part to we have this anchorage from here, and we have this minor connector here and major connector in the other part to be giving bracing for the tooth. So if we put the occlusal wrist here, you will tend the denture to be flipped. But when you go to mesial, it will transmit the force more toward the not one tooth, as you can see here, to between two teeth. So it will be less pressure or less stress upon the terminal tooth and the tooth beside it. And we can use the last part from this distal side to have the minor connector and major connector. So let's read our option to conclude the answer. He's asking about the folds. The rest seat on the terminal tooth should be placed on the distal of the tooth. No, it should be in the mesial. Retention is obtained using direct and indirect retainers. Yes. Maximum tissue coverage is desirable. Yes. Support for denture is obtained from both teeth and tissue, which is correct, because here we speak about class 1. And for this type of question, I would recommend you to go with false or right to circle it, so you can go, okay, when you read the option, you are not like confused. You are looking for the false statement, not the correct statement. Okay? Again, from prosthesis. Which of the following is not seen in combination syndrome? Downward growth of the maxillary tuberosity, increased vertical dimension of occlusion, papilliary hyperplasia of the hard palate, loss of alveolar bone in the mandible. Before we get to conclude, we need to know what's the meaning of combination syndrome. There's the combination syndrome, and this is very common, and you can see it a lot in the office when your patient had lost all his upper teeth and all the lower teeth posterior, and he has only the lower anterior teeth. This is very dangerous. Why? Because here the lower anterior teeth is like stuck in your bone of your patient, and whatever you're giving him a denture here, the forces between the natural tooth and the denture here will be not in equilibrium, and these teeth is way stronger than the denture, so the tooth here or the teeth in the lower anterior will keep hitting the denture up, and this force will be transmitted to the anterior bone in the maxilla. When this happens, there will be a loss of bone here. This is the first thing to happen. Then you will have a perihyperplasia palate because this palate is receiving a lot of trauma. Then you will have down growth of the maxillary tuberosity because the tuberosity is trying to compensate for this because the denture is flipping every time the patient is hitting the denture here in the posterior part is going down. This space will induce the downward growth of the tuberosity. And then we have bone loss in the posterior area because these teeth are missing. Maybe your patient have a partial denture and lower, maybe he has no partial denture and lower, so it will go like a ball of ice. When you have like ball of ice is going down, it will like it at start it will be small, but with time it will be big and give your patient a lot of problem. So in this combination syndrome, what's going to happen by like in order? Loss of bone from anterior portion of the maxillary ridge, because as we said, difference in the tension between the lower natural teeth and the upper complete denture, and then downward growth of maxillary tuberosity, papilliary hyperplasia of mucosa of the hard palate, extrusion of the lower anterior teeth. So when we have extrusion of the lower anterior teeth, what do you think about the vertical dimension? Loss of alveolar bone and ridge height beneath the mandibular removal partial denture base in this area. There are 6 associated changes observed in combination syndrome as follow. Loss of vertical dimension of occlusion because this teeth going up and this maxillary tuberosity pushing the denture in the other way. So the vertical dimension will be lost, not increased. Occlusal plane discrepancy because the denture cannot like keep up with this bone loss and the tuberosity coming down. Development of Ibras fissuratum as we see papilliary hyperplasia in the palate. Anterior septal repositioning of the mandible. As mandible is going to hit again, you can see your patient, I'm not saying to be class 3, but the mandible will reposition anterior and your patient profile would be like horrible. Poor adaptation of prosthesis because you need to do reline and you need to check it again, and periodontal change because these teeth are going to migrate up to compensate for this difference in compression between the natural teeth and the complete denture. All this will happen with the combination syndrome. This combination syndrome has different name, which is Callis syndrome. Callis syndrome. You should know the names. You should know the sequence. I'm sorry, but you should know the sequence because, like, if you understand it, it will be easier for you to know the sequence. Okay, so let's read the option to conclude the answer. Downward growth of maxillary tuberosity. Yeah, again, it's not. We're looking for the long option. Increased vertical dimension. No, we say this other way. Beta hyperplasia of the hard part correct. Loss of alveolar bone in the mandible correct, as we have removal partial denture in the mandible. I hope this is obvious for you. You can go just back to the previous slide to read it again. And you can download the PDF. I think you know from the upper here side, you can download the PDF and you can have it and you can do it. Again, from prosthesis. A patient present complaining that his upper complete denture does not fit anymore. Stop here. Let's understand. So our patient, he didn't give you age, but like he giving you complete denture upper. So you can think his old patient does not fit anymore. It's not like falling down while eating. No, does not fit at all. Intraoral examination reveals an erythematous palate with fibrous enlargement. Stop here. So clinical picture giving you this like in the palate. You can like visualize it now. You are a dentist. You can visualize it now. Patient coming saying I cannot put my denture, and then you palpate it. You see some papilliary hyperplasia in this part. Which of the following is the most definitive management here? And this is extremely important in the exam because like if I change this to be initial management, boom, completely different answer. Same question, same option, one word, boom, you are gone. So please, when you read the question, do not be intimidated by long question because this I received this feedback a lot. When you see a long question, it's clinical question. Should be a fundamental knowledge exam. No, no, you are a dentist. Please tackle this exam as you are a dentist because you are a dentist. They are trying to give you different scenarios. They're trying to tip you off. They're trying to manipulate your mind. This is a very long question. No, you are a dentist. Full stop. What's the definitive management of this condition? Prescription of appropriate antimicrobial, like come on man, like your patient have papilliary hyperplasia. If you give microbial antibiotic, like what's going to do? Like antifungal, what's going to do? This option is valid if our patient have fungal infection, candida infection. Fabrication of a new denture. Okay, amazing. If you fabricate a new denture, you will take impression whether your patient have this condition, how you are going to fit it, and how you are going to fabricate the denture. And when the denture come back, you put it inside. Make no sense. Surgical excision and fabrication of a new denture. I would tend toward this one. Incisional biopsy. Okay, and this option is valid, but let's think about it. Okay. So we need to reach a diagnosis. So this is the clinical picture. You see this one, like this is like very exaggerated, but like for you to understand the condition, most commonly it will be this part, but this part is like very exaggerated. Is inflammatory hyperplasia a reactive tissue growth that usually, although not always, develop beneath a denture? Some investigators classify this lesion as part of the spectrum of denture stomatitis. It's appear related to the following: an ill-fitting denture, poor denture hygiene, wearing the denture 24 hours a day. You know, some patient just leave with the denture because he feel it's good fitting and he feel like lazy to take it out at night. Like, you know, some patient so lazy not to brush before they go to sleep, and when you have the denture, he will have the same mentality. Inflammatory hyperplasia usually occur on hard palate beneath a denture base. Early lesion may involve only the palate vault, although advanced cases you can see here cover most of the edentulous area. Less frequently, this hyperplasia develops on the edentulous mandibular alveolar ridge or in the surface of Iblis fissuratum. It might happen, but in rare occasion. So this is a condition we have. So why we are going to do incisional biopsy? Because like we do incisional biopsy when we have something we don't know what it is. So we cannot conclude that diagnosis. We cannot say, okay, there's a treatment line for our patient. But here you see mechanical trauma, you see patient with alphatic denture, you see problem with your patient. So you don't need incisional biopsy. You should give your patient an solution. And here, like again, that's why I did like read it again. Here asking about definitive management. I'm asking about definitive management. And even if we ask about initial management, incisional biopsy is not a valid option because I know this. Like incisional biopsy, as we said, we do biopsy if we have a problem that we don't know it. We don't know the diagnosis. We don't know what caused this condition. So we do incisional biopsy, or we give some medication and it didn't work. So we do incisional biopsy to conclude the situation and then to give the correct treatment. Here we know what it is. So we are going to remove it and then give our patient a new denture. For very early lesion inflammatory hyperplasia, removal of the denture may allow the erythematous and edema to subside and the tissue may resume a more normal appearance. The condition also may show improvement after topical or systemic antifungal therapy. Again, this is an initial part. This is an initial condition, not in this type of condition. For more advanced and collagenized lesions, many clinicians prefer to excise the hyperplasia tissue before fabricating a new denture. Various surgical methods has been used, including the following: partial thickness or full thickness surgical plate excision, curettage, electrosurgery, cryosurgery, and laser surgery. After surgery, the existing denture can be lined with a temporary tissue conditioner that acts as a palatal dressing and promote greater comfort. After healing, the patient should be encouraged to leave the new denture out at night and keep it clean, not to go with the same condition again, to come back for you after maybe 6 months or 1 year with the same condition again. So when you read the question, you should get the clinical picture inside your mind because you are a dentist, and then you can conclude. Here we speak about definitive. Patient has erythematous palate with fibrous enlargement and cannot fit his denture. So we cannot just give him medication, let him go home and ask him to take the denture out. Here we need to intervene. You need to use your sharp plate to get rid of it, give him the denture as a temporary solution, and then when it's healed, to give him a new denture, and most importantly, to give him instruction not to develop the same condition. Again, I think enough with procedure. Let's go different discipline. Implant. Which of the following implant placement measurement is incorrect? Implant should be placed 3 mm anterior to the mental foramen. Implant should be placed 2 mm superior to the mandibular canal. Implant should be placed 3 mm away from the adjacent implant. Implants should be placed 1.5 mm away from the root of adjacent teeth. Before we get the answer, let's get the concept and then it's easy for you to get the answer. Requirement for maxilla for implant. Anterior maxilla, minimum of 1 millimeter of bone should be left between the apical end of the implant and the nasal cavity. Posterior, a minimum of 1 millimeter of bone should be remain between the apical end of the implant and maxillary sinus, and avoid midline because you potential injury of the incisive canal. So there's a guideline for the maxilla. At least 1 millimeter for nasal cavity and 1 millimeter for maxillary sinus is enough. You cannot go your implant inside it, and you cannot do implant in the midline. For the mandible, what's the guideline? Space of 2 millimeter minimum should be left between the implant and the superior aspect of inferior alveolar canal, and a space of 2 millimeter should be left between the implant and the most anterior aspect of the loop, which is the mental loop, approximately 5 millimeter anterior to the mental foramen. And here you can see this picture. So 2 millimeter here, and then there's a mental foramen which you see in the X-ray, but the nerve here is doing a loop here, extending 3 millimeter to be 3 millimeter, approximately 3 millimeter anterior to the mental foramen. So to be safe, we are going to say there's a mental foramen, what we can see in the X-ray. So we are going to go mesial to be 5 millimeter here to be in the safe side. We don't want to injure the inferior alveolar canal. So for the mental foramen, we go 5 millimeter anterior to it to avoid this soft tissue loop. And as a general rule, adequate bone width to allow 1 to 2 millimeter of bone on the lingual and 1 to 2 millimeter of buccal aspect of implant at the crest level. So the implant should be placed to have 1 or 2 millimeter buccal and 1 or 2 millimeter lingual. But we can say 1 millimeter is the minimum. We can go like 1 millimeter is not the optimum, but like when we speak about the upper anterior, the thin pole of the labial part is very thin, so 1 millimeter is not desirable, but like you can go with 1 millimeter, but recommended to be 1 to 2. Adequate space between the implant and the natural teeth to be minimum distance 1.5 to 2 millimeter. So if you see question speak about minimal, it will be 1.5. Speak about optimum, it will be 2 millimeter. Okay. Adequate space between the implants. Minimal distance between implant A3 because like 1.5 plus 1.5 A3. To ensure bone viability, allow adequate oral hygiene, allow for adequate interdental papilla. So it's not only about the bone healing, it's also about the oral hygiene because like if you have two implants very close to each other, so there is no space adequate for interdental papilla to happen. If you don't have interdental papilla, so patient cannot clean, food will get stuck and your implant doomed to be failed. That was the whole guideline for this one. So here, which is incorrect to be placed 3 millimeter anterior to the mental foramen. As we say, it's 5 millimeter just to be safe because the mental foramen loop is 3 millimeter. So we go 2 millimeter more because we cannot measure it accurately. So the average will be 3. So we add 2 more to be 5 millimeter and then to have adequate bone here in this part and to avoid injury to this vital structure. That was all for this newsletter. Hope that will be beneficial for you. I know prosthesis is like not a very popular topics when you study for AFK, but it's still important. You should know about it. You should tackle it because like you should know about it. It's in the question in the exam. Most commonly, the question from this discipline is not very hard, but I see some dentists like not paying a lot of attention for this. You can solve the next 5 questions for the next newsletter, and then for the previous one I will like by time I will try to make the quiz for the 5 questions. So I think it's a good idea really, not just have the question with answer. To get you a chance, just solve it. 5 questions, it will take like maybe 5-7 minutes for you, and then to watch the video to get the answer, to get everything. Hope that was beneficial for you, and see you next Sunday.